Hi, my name is Jerry Hesch. I'm a physical therapist. I work in Henderson, Nevada. And I want to discuss a medical test that I developed for evaluating peripheral neuropathies involving the three nerves that are proximal or within the inguinal canal. And highlight just very briefly the difficulty in getting appropriate medical care. I went 32 years underdiagnosed. And these nerves, when you have a traumatic neuropathy involving these three nerves, the amount of pain is really profound given what they innervate. And my belief was that I had injured a plexus, which is many nerves inside the pelvic basin itself. At age 17, I went from being an undefeated state wrestling champion to being having a profound pain syndrome that limited my ability to participate in physical activities. And I fractured my pelvis. It bled into the scrotum. I had to wear a kidney belt. The pain was profound, and the diagnosis was very inadequate. And for the next 32 years, the diagnosis was very inadequate. I was very fortunate to have a family doctor who really listens. Her name is Amy Sparks. She practices in Las Vegas, Nevada. She was the first and only person to ever offer to even screen me for a hernia. Well, she didn't think I had one. I didn't think I had one. But when she did, she, put her finger inside the inguinal canal. And that is how you evaluate a inguinal hernia. Now, the inguinal canal, it's a canal that basically extends here, and I'll show you in the anatomical book. When she put her finger inside there, it felt like, like 220 volts. The pain went through the ceiling, but the light bulb in my head, it not only turned on and flashed, but it exploded. Because at that moment, I understood empirically that this chronic and severe pain syndrome was not a plexus inside the pelvis, and I'll show you that plexus in the anatomy book. And because the pain was very diffuse, poorly localized, that's another reason why I had that belief. Anyway, the light bulb went on, and I understood that it involved a peripheral nerve, if not more than one, and I believed in my heart of hearts that it was then treatable. And we went through a process of conservative care, and none of it was lasting. The injections could isolate it and reduce the pain for a while, but it was not lasting. And then ultimately I found a general surgeon who was very familiar with the problem, and he came over here, medial and superior to the ASIS, made a small incision, and this is where the three nerves gather. And his statement was, I'm sure I can find one nerve. I'm sure I can find the ilioinguinal. He says, I'll wear a 10-piece loop, 10x loop, so I can visualize, and I'll tease away the fascia, fat, whatever, and then I'll look for the other one, and there's a good chance I might find the other one, but less so than the first. I think, and then the same thing for the third one. Then he would cut the nerve, but he would then suture it into muscle, and so the end of the nerve would not develop a painful stump, which is called a I just forgot it. I'll come back to it. But at the end of a neuroma, a painful stump. And he did the surgery, and it was remarkable. So now I'm numb in this area, and I don't care. If I ever get a true bulge, a true hernia, I'm sure that when I tuck my shirt in, which I do regularly, I'm sure I'll feel that bulge. So lacking sensation is a gift. And I am profoundly better. I mean, I couldn't even sleep with this pain for years and years and years. Turning in bed was extremely painful. So I developed this test in which you put your finger inside the inguinal canal, not for the purpose of screening a hernia. You do that first when indicated, but this test, you are specifically going in there to scour the three nerves that are either within or proximal. I'll elaborate on that later. Now, you can clearly, in a male, feel the spermatic cord. It's a very thick structure, and if you rub across that spermatic cord, the nerve that you're capturing at that point most likely is the ilioinguinal nerve. Okay? Now, on the roof, and even external in some people to the canal, and there's a wide variation in this anatomy, is going to be the iliohypogastric nerve. Now sometimes it joins and goes in the canal, sometimes it's external to it, to my understanding, and I could be wrong, I'm not an anatomist. And then the other nerve is the genitofemoral. Okay? So by scouring inside there, you can, get a sense of what's painful, and the surgeon tells me, look, you can't feel the nerves. It's odd, because I would just swear that I feel something fibrous, and I don't think it's an artery. Maybe it is, but I truly feel something fibrous that feels like a nerve to me, okay? And my point, and my debate with him, I said, well, if you're not feeling the nerves directly, you're at least feeling innervated structures. And that's where that went. So once again, I put my finger inside the inguinal canal, and then I scour all around. If it's a clock face, then I'm going from 12 to 3 to 6 to 9 to 12 o'clock again. And then with respect to the spermatic cord, you can rub up and down or across it, and you can even come down out of the canal and capture it. Once you isolate it, it's very accessible at the very top of the scrotal sac. In the female, the canal is much narrower, and they don't have a big thick cord going through it, but they do have the round ligament of the uterus coming through and inserting right here on the pubic tubercle. Because it's a narrower canal, it's stronger in the female because of a lesser diameter, and it's very rare for a female to actually get a hernia here. And I had a telephonic consult with someone recently who actually, who's female and actually had a hernia repair here. I have another client who I've been communicating back and forth forever and ever and ever, and she was convinced that it was her SI problem and this and that, and I just kept believing that there was more to that. And she lives far back east. I've tried to get her to see a couple of people, and with very mixed results. No one has been able to help her. And finally the light bulb went on very recently, and she came to realize that right after she had the removal, she had female surgery, removal of the left ovary. Right after that is when her life, with respect to pain syndrome involving this whole area, went to hell in a handbasket. And I've been, communicating with her recently and saying it sounds like you might have a neuropathy involving at least the ilioinguinal nerve, but maybe genitofemoral and maybe iliohypogastric. And it might even involve the femoral nerve, which is very proximal, goes down the front of the thigh and innervates the quads. And there's actually a couple of femoral nerves. There's at least 3 of them. There's the main one, and then there's the lateral femoral cutaneous, which is sensory, and then there is a femoral branch of the genitofemoral nerve, which goes down a little bit of length, and then I think it hooks into the femoral artery, and I don't think anybody knows how far down the thigh it goes. So anatomy is an evolving science. She might also have involvement of the obturator nerve, which is very, very close. So we have lots of nerves that are very close in their formation, where they come from and where they distribute. And there's a lot of overlap too, which I'll show you in the anatomical text. I think I've covered